Welcome to the NEI podcast. On this show, psychiatrist, psychopharmacologist, and mental health advocate, Dr. Andrew Cutler sits with renowned mental health experts from a range of backgrounds to discuss breakthroughs and best practices for treating patients with mental health conditions.
Hello and welcome to another NEI podcast. I'm Dr. Andy Cutler, and I'm here today with Dr. Ryan Sultán from New York City, who is in ADHD and is a child and adolescent psychiatrist and does a whole lot of interesting work on a variety of issues, including substance abuse, which it's hard to talk about ADHD without it. So Ryan, how are you?
Good. Very happy to be here.
Great. Well, you know, Ryan, I've been treating and studying ADHD for about 30 years now, and in that time, there's certainly been a lot of advances in our understanding of the illness itself neurobiologically, clinically, and certainly our treatments of the condition, but yet there are still some misconceptions and, a lot of baggage around the topic, shall we say. So let's just sort of get into it. First of all, what would you say has been some of the biggest advances in our understanding of ADHD?
I think that for me, what I think is most interesting and important about ADHD is when we think about all psychiatric conditions, all mental health conditions, and we try to think about this old environmental versus genetic thing, which of course is an oversimplification. ADHD we always knew was super heritable, right? First degree relative, very close, and we also saw this other thing. So that sort of smelled like genetics, not exactly, but close. And then this other thing we see, is this effect size, this response to pharmacology that is better than any other medication we have in psychiatry for any other condition, period, right? Like it's really interesting. And so for me, I always thought, okay, well, what does that mean? Those things do not mean that it has a biological basis to it, but it certainly smells like it. And, there were early findings that showed EEGs and they showed slow wave, which is sort of like almost asleep. And you're like, oh, you can imagine an inattentive individual like that. Well, there's a biomarker. And then more recently, there have been SNPs that have a relationship for it. So that gets into an actual, gene, actual DNA. And then lastly, that I think is cool is the functional MRI findings that you see, you're like, okay, well, we know dopamine is somehow related to this because these meds that change dopamine seem to affect the individual. And when we look at their brains and we look at like dopamine activity, it's different in these ADHD individuals than it is there. And when you give them the medication, their brains look almost the same as the non-ADHD brains. And I'm just like, that's a great story. I think that's a better story for like thinking about how to put a biological understanding of ADHD together, which is obviously part of it.
Yes.
Than I think anything else in psychiatry.
Yes. Yeah, I certainly agree. And as a matter of fact, as far as genetics, it's also probably the most genetically linked heritable condition that we treat, with some estimates 80 to 90% genetic. It's almost as genetically determined as your height, which I think people would agree is pretty genetic. But of course, we don't want to just be reductionistic and say this is only, just like we wouldn't with any of our conditions or any medical condition either. I think it's always a complex interplay. But as you said, clearly there's a neurobiologic underpinning to this, and there's all kinds of neuroimaging studies that show differences in the ADHD brain. But I think the issue is, too, there's a heterogeneity, so to find maybe one genetic link is a little naive. Mm-hmm. There's probably a lot of different ways, I say, to catch ADHD, if you will. And so the consequence, of course, our treatments, our interventions need to be, of course, multifactorial, multidisciplinary, right?
Absolutely. It's what exactly is ADHD is like a big question, right? Evolutionary psychiatry has proposed that ADHD is not a disease, that it is a potential adaptation, that in a hunter-gatherer society of 100 people, everyone well, like the one that is running at like a low level, that slow wave sleep, like not really paying attention. But when you get this person excited, they are like full on in. That sounds like a great person to have on your team. Someone who might be curious and be like, hey, we don't need to pick every berry from this bush. Let's go check another bush out, right? Like that some of those things would be potentially adaptive. And, so that's one idea on it. I think that's something that we have to sort of be thinking about, like, could that even be true? It's a difficult thing to test empirically, but what's interesting about it for individuals with ADHD is it to me, it flips the story from the "you're broken" stigma story around to a mismatch story.
Yes. Interesting. Yeah, I like to say ADHD is not good or bad. It's just different. It's a different way of processing. And the theory you're referring to was actually published by Peter Jensen many years ago, this evolutionary theory, which I subscribe to as well, Ryan. I mean, if you think about it, people with ADHD are they're the warriors, the explorers, and the inventors of society. And so let's say you and I are living in a village, and our water supply, we're by a river and the water supply runs out. Well, the ADHD person's going to say, well, a couple of days ago, I was out exploring and there's a couple valleys over, there's a stream, we can move, our village and we survive. And then if another tribe attacks us for our food or something, the ADHD people band together as warriors and, fight off. And then, of course, the inventors invent tools and fire and so on. So I think it makes a lot of sense. It is controversial, like you said.
I think, though, when I first started learning about this idea, I was enamored with it, and I'm actually still enamored with it. But I thought about it a little bit more, and I've been asked to look at data around attention, and how devices and social media are affecting that. And there is data among ADHD individuals in particular, but everyone, that some of the systems we're interacting with, particularly these high intensity, bright lights flashing, going things quickly. I mean, imagine like TikTok videos actually seem to be worsening one's attention capacity. And I say that because is that what we meant by ADHD, decades ago? No, that's not what we meant by ADHD. But you can't help but wonder if it's still there's a range of where your attention might fall, or where your capacity for impulsivity and management might fall, and what external factors might move you along on this range.
Yeah, I agree. You know what I've always thought, tell me what you think of this. I've always thought ADHD was completely misnamed, that all four of those letters are wrong. It's not attention deficit, it's attention regulation. How often do you have a mom come in and say, he can't have ADHD, he can watch TV for hours or play video games for hours, he can pay attention. But of course, it's interest-based, and then hyperactivity is not necessary. And then we just talked about, I don't think it's a disorder. I think it's a difference that is contextually and environmentally based to some degree. Does that sort of stack up with how you see it?
Yeah, I think the regulation is actually the word that really is not used enough around ADHD, because there's also emotional dysregulation that people with ADHD are more likely to have. And how much of that might be secondary to the sort of adverse effects of experiencing life and struggling with ADHD is unclear, but it's been written about for a long time. Earlier, the terms that predate ADHD, minimal brain dysfunction, what an awful name. Can we just sit with that for a second? Like, what was the DSM committee thinking? Like, oh God. But it used to, some of the earlier versions of it talk about regulation of emotion and affect too. So it's a lot about regulation.
That's right. Well, if you go back to some of the original descriptions, you're right, from the 17 and 1800s, they talked about resistance to moral authority in the Victorian era, but they talked about stubbornness and emotional dysregulation. And actually, if you look at the prefrontal cortex, there's actually 3 circuits it regulates, not 2. It regulates circuits of attention, it regulates circuits of motor activity and impulsivity, if you will, but it is also a superhighway regulating emotional regulations, if you will. And we think that a lot of the problem here is dysfunction in the prefrontal cortex to some degree, or difference, I guess I should say. But okay,
what about
great.
the idea?
Yeah.
What about the idea, though? So I think there's another dimension to it, right? So dysfunction versus difference versus like mismatch. I think are sort of one ways. But what about the idea that it's there's also a delayed maturation phenomenon that seems to be going on, right?
That's actually been shown. There's a famous series of experiments by Shaw and colleagues that literally show that. And people with ADHD intellectually track with their age, but emotionally lag by 1.5 to 2 years. Yeah. And Shaw showed literally parts of the brain lag in their maturation by that amount. So you're right. We have a biologic correlate of that.
This is great. I think this is so wonderful that we're able to sort of think about this and slice and dice it in so many different ways, because it really is so much more complicated than I think the general public understanding has been distilling it down to.
Yeah, I think because, first of all, we're all on a continuum of attention and behavior, of course. But I think because it sort of looks like almost willfulness, or because in some situations they can perform and some they can't, there becomes this judgment that's affixed to it. Mm-hmm. And you mentioned it beautifully, the emotional frustration, the low self-esteem from getting negative feedback and from the failures. And so unfortunately, there's a lot of misunderstanding. And then, of course, the medications have so much baggage because they're potentially abusable and so on. So yeah, I think there's been a whole lot of, misperception about it. But as you've said, gosh, we have so much understanding now of the neurobiology and the genetics. This is a real neurobiological medical illness, if you will. Another misperception now, I'm older, I trained over 30 years ago, and back then there was no such thing as adult ADHD, Ryan. We were taught you outgrow it. And that never made sense to me, either just neurobiologically or clinically seeing people with ADHD. Of course, the brain matures and it changes over time, but I think we have a better understanding now that it persists the majority of the time. Yeah.
Yeah, it certainly does. The studies support that 2/3 still meet criteria into adulthood, and that 95 or something % of people have at least residual symptoms. So there's something there. Why wasn't it recognized before as an adult, a disorder that continues into adulthood? I've thought a lot about that. I think one aspect of that is that we do know that there is that maturation, that delayed maturation, and that pretty much reliably anyone with ADHD will see some lessening of the sort of variation in their symptoms versus maybe their peers or their behaviors or, how they experience it. Because that's a pretty reliable thing that people experience. I also wonder again, I feel like we in sort of, particularly in like Western societies, have been moving in more towards a rigid, narrower, restrictive experience, and I think that creates it's sort of putting pressure on the person and making the symptoms come out a little more than maybe they used to. And one of the ways that I came up with that is I've spent a bunch of time. I'm obsessed with hunter-gatherers. I just think it's so fascinating to think about the anthropology of whatever. So whenever I've been in places where you can interact with any kind of tribal group like that, I talk to them, and if you ask them about ADHD, I've now heard this from 2 different groups. They basically don't know what you're talking about. Then you describe it and they say, well, they're like that and that's how they are in our tribe and it's fine. But once we started sending them to these schools that you guys have, suddenly it was like an issue.
That's right.
And I thought that was so interesting, and it sort of supports this evolutionary idea.
Yes.
And there's been, at least in the US, physical activity which increases dopamine and manages symptoms.
That's right.
Has gone down in schools, right?
I agree.
Down in schools.
Yes, definitely. No, I 100% agree with you, and it makes me think again of a historic term was hyperactivity disorder of childhood. And so the overt hyperactivity, of course, gets better over time, and we learn coping skills. But also think about it. The ADHD brain, there's some things it actually does quite well, but school is not one of them. And when you're a kid, you can't choose your environment. You're put into these restrictive schools. But when you're an adult, you can choose there's certain careers and jobs that maybe play more to your strengths. There's some professions, for instance, firemen, military, police, professional athletes, sales, and other things, creative. They have higher ADHD. So you're absolutely right. And then the recent research you may be referring to by Maggie Sibley and colleagues, where they followed people over time on the persistence, Previous estimates that were 50-60% of persistence were based on point prevalence, 1 point in time. But Maggie's sibling colleagues followed them over years and found, no, it's actually 91% of the time, but a lot of times it waxes and wanes depending on the environment and the stress, as you've said. So,
and that just came out of the MTA data.
That's exactly right. That was from MTA.
The newest MTA data by Lily.
Well, that was Maggie Sibley's article that she just published.
Is that
that's the Sibley article? Yeah, from MTA.
That's the Sibley article. Yeah. I saw them present that data, and I just thought that was fascinating. And they said we were surprised by it, and then we thought about it, and we said, actually, this is not surprising at all. This is totally consistent with our understanding.
Yeah, and as you said, of course, too, the cognitive load and the cognitive demand has increased on us, I think. And that's what really challenges the adult ADHD brain to some degree. Okay, let's. What
I'm interested about is what happens when these folks that we've now identified get older. There was one article that came up very briefly that thought it showed a link between that and like Alzheimer's, and that was a very small thing. Like they thought, but it's like you can't help but wonder, right? Like what is the progression of this? Like we think of schizophrenia as a biological disease, and like that has certain associations with it. Does ADHD have any variation to it?
I think that's really well said, Ryan. And how does that interact with the aging brain, whether normally or pathologically aging? I totally agree with you. I've had adults present saying, I think I have dementia, when it turns out it really was more ADHD. So that is a fascinating, complex interplay. And then what does treatment do for that?
The Tim Willens thinks that Tim Willens, he's like a big shot in this. Right?
Oh, he's on the NEI faculty, good friend of mine. Yeah, he's terrific.
Yeah,
I agree.
He's my mentor for my K award.
Oh, lucky you. Lucky you.
I know. I love Tim. If you're listening, we love you.
We love Tim.
He really believes that there's enough evidence to say that the treatment may actually really improve maturation in a positive way.
There are data supporting that. You're 100% right. And he's also done a lot of work, as you know, on substance abuse and ADHD, and has shown that as long as somebody's not currently actively abusing, that appropriate treatment decreases the risk of relapse and substance use, which is...
I don't know why we have to keep asking that question. That question has been asked like 7 times, and every time the answer is no difference or improvement. People are just like stuck on this idea.
Well, let's get into treatment, shall we? And the focus of today is not going to be the whole holistic, multimodal treatment, but I want people to know, Ryan and I, of course, both agree how important that is, but I think we're going to focus more on the medication, since that's pretty controversial, if that's all right. We have seen the diagnosis be increasing. As a matter of fact, right now, the fastest growing group of people being diagnosed and treated is women, especially women of childbearing potential. We've seen prescriptions rise steadily. So what do you think is driving the increase, and how should we be interpreting it?
We've touched upon some of these factors, I think, that we can kind of pull into this story. It's been going up for a while. It's been going up for over 10 years. We know that there was a significant increase around the pandemic. And, how much of that was related to the pandemic versus like online availability of it, I think is not clear to me. And it's not just in the US. The Swedish data, demonstrates that. UK data demonstrates that. And we've always been ahead on diagnosis rate. I shouldn't say ahead, because ahead assumes it's positive, but like our prevalence rates have always been higher than Europe, but they're starting to catch up with us. So it's definitely there. And look, I think there's many explanations. The classic explanation is, we missed people before. It's like the public health explanation. Like, now we've found everyone. Isn't this wonderful? And I think that's true. That's certainly some of it. There's no secret that ADHD for many years was underdiagnosed like across the board. That was true for a very long time. I think the next thing that you think about is like, well, has diagnostic criteria been expanded? And it has been. The age for presenting symptoms has been raised, which allows more people to be incorporated. I think both of those are true, but I think that the I think that there has to be other factors driving it. I refuse to believe that at this point it's just those things, which is where I say, look, is this a neurobiological condition? Of course it is, but like it can't only be that. Even if the changes are epigenetic and they're from some, or maybe it's people that have severe complex trauma that is interacting with some pre-existing propensity that they have with that, and now they're presenting with symptoms that overlap with ADHD. I think there's a number of things that could be going on there that we have to be thinking a little bit about at this point, because we want to be sort of thinking about where it is. But for the most part, the data I think has been mostly that milder cases, I think is the other one. I think milder cases are just being caught more and more, or milder cases that are sort of maybe because of this other epigenetic cultural thing are getting sort of knocked over into our court in a way they weren't before. And the treatment is obviously up because, stimulant prescribing in the US has increased substantially.
Yeah. I think you're really onto something with everything you've said. I think there's increasing recognition and diagnosis. Certainly, we're also recognizing the severity of the illness and the outcomes of the illness, the impairments, but also medical complications. So it's kind of put more of an urgency on recognizing and treating. And then I think you also say it well. Boy, our society has gotten more complex, digital things, social media, all this stuff coming at you. And I think it has uncovered milder forms that maybe could have compensated years ago.
Yeah.
That now the wheels are falling off a little more, if you will. It's such a cognitively driven society, and AI now, of course, and all of that. I don't want to get into that. But so I think you're right. And along with that comes the fact that, darn it, none of us, Ryan, I don't think we want to prescribe stimulants, but we have to because they're so darned effective, right? We just don't have non-stimulants that are quite as effective. I know Tim's a proponent of appropriately using non-stimulants when appropriate, but I think...
And they're great.
Yeah.
You can get a lot of miles out of bupropion. I mean, that drug, that's why they keep recreating it in different versions of it. It's a great medication. It's very well tolerated, and I've gotten a lot of miles out of that as a start. I almost think of it like Lantus, like a background long-acting insulin or something, for ADHD, because you don't have the sort of peak. No one ever complains about peaks and valleys on it, and the end of the day, feeling like it's wearing off.
Yeah. Well, and you get a 2-for-1 there. It's an antidepressant. There is a medication that is on the market and yet being studied for ADHD, solriamfetol, the brand name is Sunosi, which I like to call Wellbutrin on steroids. It's a more potent version. It's a DNRI. There's also Viloxazine extended release, and there's another one, Centanafidine, a triple reuptake inhibitor that's in development. So, hope springs eternal for more effective non-stimulants, which may also help with some of the comorbidities, depression and anxiety and so on. But darn it, we still have to prescribe stimulants, it seems like, either by themselves or in combination. And we know that the prescribing of that has gone up, and we know they're controlled substances and abusable. There's a recent paper in JAMA Psychiatry you and I have talked about, published by Lee, L.I., that looked at prescribing trends over time and the outcomes. And do these findings align with what we see clinically?
Yeah, I think that as I recall, the way that they sort of think about this is outcomes are improving, right? So, which is great. That's what we wanted to know. We wanted to know that medication doesn't just reduce symptoms, because at the end of the day, that's nice that you and I can write down that the symptoms are better, but did we improve someone's quality of life? And that's been pretty reliably shown around accidental injury, speeding tickets, car accidents, things that are really concerning events. And it's been shown in multiple different data sets, including this one. The interesting finding about the JAMA paper is that they showed that as you got to sort of the next level of treatment, the improvement you saw was not, you weren't getting as much bang for your buck as you were early on. And of course, because who's the first people that you treat? The most severe cases, right? The most impaired. And so they have a lot to gain. And the sort of more, milder or moderate ones, or were well compensated or whatnot, they don't have as much a sort of runway that, to work
Right.
through.
Well, especially if you look at these outcomes that they were looking at, like you said, traffic accidents, self-injurious behavior, crime even. Well, that's low-hanging fruit to some degree. They're not necessarily looking at things like self-esteem or things that are softer outcomes, I guess. You know what else related to that, Ryan, that's really amazing is some of the emerging data on the mortality, premature mortality associated with ADHD. There was a famous paper, the SUN paper in 2019 that showed that there is increased premature mortality with ADHD, either by itself or when you start layering on comorbidities, the risk of prematurely dying goes up logarithmically. And that comes from suicide, believe it or not, is higher, accidents, and then natural causes, cardiovascular disease, diabetes. As a matter of fact, one of the highest genetic linkages with ADHD is increased BMI, believe it or not, obesity. I would have thought it's depression or anxiety. And then you may be aware of a really groundbreaking recent study just published February of this year. The first author is O'Nions, O''Nions. Looks like onions, but it's O'Nions from the UK. And they found with ADHD, men die on average 7 years earlier and women die 9 years earlier. And as you said, there are other studies that show treatment can decrease these things, can make an impact on these things. So I think this is the call to action, Ryan. This is a serious medical illness.
Absolutely. That is something that I felt very strongly about. One of the first things I wrote about on ADHD was right back in 2012, looking at adolescence and looking at the adverse associations of having ADHD. And, the likelihood of having a comorbidity is like 70% of people with ADHD had some other psychiatric comorbidity. Like that's almost the norm, right? Like, and then I remember we used this national survey at the time, and suicidal thoughts were like twice as high in the ADHD group, right? We actually quantified it. It was twice as high for them. A number of things that also happened, like getting expelled from school or losing a job 4 times higher. Problems with the police 4 times higher about. Suspension from school 4 times higher. I mean, this is very significant, right? So, and that's one of the things that really have pushed me to be a little bit evangelist around like treatment. And I tell families when they come in, I say, look, I'm very like collaborative. I'm like, look, I'm going to tell you what I know. I want you to understand the condition the way I understand it, so we can make a decision together, and that you'll have like buy-in on the decision because you'll understand the logic of it. And around treatment, like, even though I know how effective stimulants are, like I have people I treat that are not on a stimulant but often what we do is we wait a while, but I often will tell them if I'm concerned, I'll say like, look, this is the line where I'm going to start saying we really need to do something. And that thing really needs to be a pharmacological intervention because of these data, right? Because of these data that we know that not treating it is so problematic. And we know that treating it actually improves real outcomes.
Yes. All very true. And I think it's very important to get buy-in and do psychoeducation, as you said. What's amazing to me is all the things you've said, the psychiatric comorbidities, but also those medical comorbidities, and treatment really can make a difference on all of these things. And I think when we're talking about, we're always doing a risk-benefit analysis. And I think when we think about risk, we think a lot about side effects, abusability. But I think you've said it beautifully. What is the risk of inadequately treating this illness?
Yes.
I mean, it's global.
There are known negative consequences.
Yes.
Versus hypothetical negative effects that you might have from a medication. So when people get into the lights, well, we don't know what it does to the brain long term. Okay, first of all, I think that's a little bit of a dramatic statement. We have a lot of information about what it does to the brain long term because we have been prescribing these medications to small children for decades. Okay? I mean, think about the number of individuals that have been on these medications for long periods of time. Like, so that already is just some general population-based data. And there's a lot of imaging that's been done, and there's data that shows an improving of outcomes. It's really something that we have an idea that treating is going to change the trajectory for them, whereas not treating, maybe you save from this hypothetical concern that you might have, but we know you increase the risk of these negative things.
Yes. Boy, that's really well said. There is, of course, a lot of legitimate concern about overdiagnosis, overprescribing, and of course, the risk of abuse, misuse, and diversion. How should practicing clinicians balance these things out and think about them in their day-to-day work?
Okay, really hard on over/under diagnosis. That's such a hard one because there are a lot of edge cases, and there's only so many people that are subspecialized in knowing psychiatric conditions and knowing ADHD, and so we have a lot of different types of clinicians that are prescribing. We have physician extenders. We have primary care individuals. I mean, we have OBGYNs that do this. So we have, we have to think about like how to manage that. I look for identifiable problems that I can monitor that are likely to be result of the ADHD diagnosis. Looking at those and then using those as a objective-ish measure for monitoring treatment. Because and seeing if you resolve them, right? Because if you're not getting miles out of it, you really need to go back and say, hey, maybe they look like they met this diagnosis, but like I'm not so sure I'm on the right track, because this thing that should be getting better, like their procrastination maybe, or their ability to sort of sit and do homework with the tutor. That should have improved.
Right. I like the thought, too, that you're saying it's not just about symptoms, but it's about these measurable consequences, if you will. And this is one way that I kind of answer the overdiagnosis question. I mean, maybe there are people trying to game us to get stimulants, but I think, so yeah, there's some overdiagnosis, but I think the bigger problem is underdiagnosis and under-recognition. And I think one of the ways I get around that is by looking for not just symptoms. If somebody's trying to game you, they'll give you symptoms. But I ask about the impact and the consequences. And after seeing people for so many years, you know what it sounds like. You know when it's real. It's not just somebody saying, oh, I can't read. I can't pay attention. That's generic. I want specific examples.
Especially in the adult population,
yes,
right?
Yes,
because at least currently in the adult population, they've grown up in an environment that was probably not so friendly to this. And so there are almost assuredly like negative like thought processes and experiences and traumas, whatever, however you want to like frame it, that they have that you are pretty clearly linked to untreated symptomology.
The other thing I've been thinking about is when a child is brought to you, it's usually ADHD, and it's pretty clear. They're having trouble academically or behaviorally, right? And it's usually pretty clear. But adults often present with the comorbidity. And so it's not as clear that it's ADHD. They present with depression or anxiety, let's say, first. And that makes it tough, too. I think that makes it challenging to recognize as well, if you're not clued into
100%.
It. Yeah.
I also think it creates problems. It's a challenging case for treatment, too, because improving the symptoms of ADHD medication in an adult, their life is still like the life that they were in, which was probably one that had a bunch of issues, which is how they ended up in your office in the first place, right? It's the same thing. Like, I mean, it's one of the other things that like really antidepressants always sort of like fail at. Like, well, even if they remove the sort of center of the depression, like this person has been depressed for like X amount of time, and like this is the life that they have to put this back together, right? And I see those in both of those cases, right? Because there's often consequences. The bed that they're laying in is not a clean, neat, fresh military, sheets.
Right. Oh, you're right. And there are, this is where cognitive behavioral therapy, for instance, is helpful with the negative thought patterns and then the negative behavioral patterns they're into and so on. With adults too, when I make the diagnosis, very often a very important part of it is grief work, frankly. When they have a realization, wait a minute, you mean I had something that was recognizable and treatable since childhood, and look at how my life has kind of gone, and maybe my life could have been better. And I will say to them, yes, that's true. I'm not going to sugarcoat it, and we have to kind of get through that, and then we can move on. And improve the rest of your life, if you will. And that may happen with adolescents as well, too. I'm not sure.
I think that I know that I know exactly what you're talking about. Like I think a lot of us do and see it over and over again. I think something that really is one of the reasons, and this gets into the idea of like pharmacology treatment is not the only thing for ADHD. And one of the disadvantages, unfortunately, with ADHD, particularly in adults being treated by non-mental health professionals, is they don't have as much of a intuitive or trained ability on how to foster this grief, this supportive work, this that can go on for months, right? Like, I mean, I've had some failure to launch cases where I think part of the problem is that we've had trouble getting out of that, actually. And so, thinking about psychotherapy, people often, you're like, think about CBT and like skills and like making lists and all this other stuff, structure, all really important. I love Anthony Rostain's book on, they told me he's been updated to the ADHD toolkit. The other aspect of it is, what is the sort of like more affective work that needs to be done? What's the other kind of psychotherapy that is meant to help them process and heal this diagnosis so that they can move forward?
Yeah. Well, separating the illness from them as a person, and you mentioned self-esteem, of course, it takes time to heal. I agree with you. So I think we agree medications are incredibly effective, but certainly not the whole story, huh? They kind of get you. I like to say it's like insulin for diabetes. I don't just give you insulin and say, eat all the chocolate cake you want. We're going to talk about, a lot more than just getting the glucose under control. So,
and there are sometimes cases with kids where it does feel like the med was the only thing they needed. I've had cases of very, very organized kids that come from families that are the family member is like a psychologist and the mothers, and so that so much has been done to structure the world for the kid and accommodate them the best they can, and they have an IEP and there's it's a regulating household, and they have all these resources, and they're like, all that's already been done, and then we come in and we just give a little bit of medication and like that's it. Like, and that's I would say that's the minority of situations, but it does demonstrate to me that, there is a version, that there's something there that we can't seem to fix without pharmacology, no matter how many different things we address.
Oh, I see what you're saying. Yeah, that's a good point. That's also a reason people get missed, if they have a structured or compensating environment. Or I had a professor, Ryan, who used to say IQ points can compensate for a lot. A really smart kid who doesn't have to study as hard. Or, you know what I mean?
Yeah.
And so sometimes then it gets missed into adulthood, if you will. So yeah, these are some other reasons for underdiagnosis and misdiagnosis, I think. I'll never forget, I had a patient who was a actually pretty famous baseball player, and he went to Stanford University on a baseball scholarship, but struggled mightily with ADHD. And I remember I was working with Major League Baseball, and they said, he can't have ADHD. He went to Stanford. It's just so many misconceptions about this, huh? Yeah. Well, let's talk quickly about, you mentioned a certain population that maybe has great structure, great socioeconomic status, but are all populations benefiting equally? Or do you think there's disparities in who gets diagnosed and who gets treated?
I certainly think that there are disparities around the quality of the care that individuals are getting. And that's unfortunately a statement that can be made about psychiatry, healthcare in general, but psychiatry in particular, I think struggles with this. Because psychiatry is this interdisciplinary space in mental health. We occupy lots of places and we have lots of different interventions, but they're all kind of time intensive. And so you not only do you need the buy-in and the interest and the motivation, and forget the financial resources. Let's even assume let's now assume it's even covered, which it often is not. It's the sort of headspace and the time in one's schedule to sort of organize around getting all this support and treatment. And that is going to really vary significantly for individuals, socioeconomic status being one of them. I think also like the sort of general psychological functioning of the world they live in, right? Like, I have very wealthy families that I've worked with, very famous families that I've worked with that may have lots of resources, but there are other things that they are not able to allow them to access all these resources because of their time, because of their headspace, because of their ability to organize.
Yeah, good point. Well, I think you're right that this is not unique to psychiatry or ADHD treatment, but I think there are some other issues too, of course, that sometimes getting these other treatments require specialization and require a certain education, so getting access to them, as you said. But also there are cultural issues, frankly. In certain cultures, mental illness is frowned upon in a way. It's more of a weakness. And so you see a lot of cultural limitations against getting recognition or diagnosis or even seeking help. I think also another problem, frankly, is not having maybe a diverse enough healthcare provider population so that the people look like you that you're seeing, if you will, that you feel comfortable culturally, that they understand.
And we know that. Yeah. We know that, right? We know that is a very reliable finding, that people do better and feel more comfortable being evaluated and treated by healthcare professionals that they think are going to understand them. Who do you think is going to understand you? Someone that you feel like you have things in common with.
Yeah, really well said. I agree. We've talked a little bit, of course, about non-pharmacologic interventions, and I guess we agree that perhaps for milder cases, sometimes that may be enough, but I think we would agree that the best outcomes are a combination of medications and various other non-pharmacologic. Do you see a role for digital therapies? There are some digital tools and digital therapies.
I want to really badly. I have not been impressed yet. With anyone's data or whatnot, but yeah, absolutely. Digital therapeutics, I just think is like in its infancy, and like there's, especially with large language models and the just-in-time sensing from all of our devices and whatever. Like I think there's a lot that can be done with that, but I'm just not sure that we've figured out how to do that effectively yet.
Yeah, I would agree. I mean, I think it just makes too much sense that it can work, should work, if you will. I just don't know that we're there yet. And of course, the issue there is getting payers to get on board. So far with prescription digital therapies in particular, they just haven't jumped on board, and there aren't enough clinicians who are champions of this. So at some point, I think there'll maybe a critical mass, and we'll see.
I'll tell you something I worry about.
Yeah.
And it's that the availability of these large language models, ChatGPT being the one that we're all most familiar with, they're free. You can get them sort of anywhere now, like in the world. That's great. They're amazing. They still make my head explode with how cool they are and what they're able to do. And they're an easy solution to trying to get help, but they were never designed around this. So there's all kinds of problems that are coming from that. And what I find frustrating is that, we have the big tech companies who, don't see themselves as healthcare providers. So they're just happy to put out there whatever happens. And like, it's not, they don't sort of think of the sort of ethical implications of that and the way we would. I think what's frustrating for me is that as we're trying to develop these things, medicine and academia, for good reasons, has many, 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 many barriers to make sure that you don't hurt someone. And I sometimes feel like we get stuck on that. And I'm sitting there thinking, but the person can go to ChatGPT and just do whatever they want in it. Like you're asking me to make this thing so much more restrictive. And I worry about that, because then I worry that the sort of ChatGPT, which was not designed for this, isn't intended for this, becomes a standard that people use, say for their organization or their treatment or their knowledge around anything, including ADHD, versus something that's actually been designed for it.
Yeah, no, I totally agree with you. And with any new technology, Gosh, we need to learn the pros and cons. We need to put limitations, restrictions, regulation in place, all that. And we're in our infancy there with AI. Couldn't agree more. I'm a little worried too, Ryan, since we're talking about this, about the role of TikTok and social media. There's a lot of unregulated information that's less than helpful, shall we say. And so I worry about the misinformation that's getting out there with these things.
Yeah. I think that the perceived overdiagnosis of ADHD, I think, has really been driven in the general population by that wave, which went on for a while, of everyone doing stuff and calling it ADHD. Oh, I leave my clothing on the floor. It's because I have ADHD. And then they're like dancing, ADHD life. And then they're doing something that could have an association with ADHD, right? It's correlated to it, but it is not a symptom. It's not pathognomonic. And so then there are all these people that are sort of like thinking that they might have this. And this is from someone who's making something for entertainment purposes, first of all. And second of all, probably doesn't have sufficient foundational knowledge for the thing that they're putting together.
Yeah, that's well said. And also, I think there's a lot of weird recommendations about things that work for treatment and all of this, and misinformation about our treatments and so on. And to your point, I always see this is much more than just, oh, I'm a little spacey or inattentive or forgetful. Isn't that cute? I mean, as we've talked about, there's a very serious condition with serious consequences and even medical and life and death complications. And so, unfortunately, you're right, this contributes to some of that misunderstanding too. Well, Ryan, believe it or not, we're running towards the end of our time here. This has been really terrific conversation. I really appreciate it. Let's see if we can just end up on, what do you see as some of the biggest challenges and opportunities for ADHD treatment over the coming years?
I think one of the biggest challenges is probably going to be how to figure out a way to provide a version of biological treatment that's a little more stable than I think stimulants are. I think that because they're so effective, to get something that would supersede them or even be seen as like similar in efficacy is going to be a pretty high bar. And so I just think, we're kind of stuck with the disadvantages of these medications, at the same time. But, I'm hopeful about that. We as you mentioned earlier in the discussion, there are other medications coming out. There is a lot of interest in biomarkers on this. And there are a lot of digital therapeutics. So I am hopeful about that.
Yeah, I would agree with you, and I'd go a little farther. I think ADHD is a very heterogeneous condition. What probably we should call the ADHDs with an S,
Mm-hmm.
And one of the challenges in all of psychiatry to me is, you mentioned biomarkers. If we could figure out which subtypes do best with which treatments, I think right now we're using stimulants because they're kind of I call it a sledgehammer in the brain. It's such a, it's just hitting everything. But maybe there are treatments that would be especially effective for certain subtypes, if you will, or certain biologic types. And so
personalizing the treatment, right? Wouldn't that be a
Yes.
nice thing for us to be able to do?
Yes.
I don't think it's going to be the subtypes, because my recollection is the subtypes are actually not consistent over the lifetime. So they seem to sort of be more descriptive of where they're, which is consistent of that finding of actually that the symptoms change over time and through experience. So that, again, like, not surprising. I think it's I think that's something we're going to have to see, but I do think that the idea of subtyping what's going on in some way is really the way to go.
Yeah, I didn't mean the subtypes of the inattentive type. Sorry, I was imprecise in my language. I meant, the different biologic substrates, if you will, the different neurobiologies and maybe different clinical presentations that go beyond simply those, you're right, those sort of blunt
it would be nice
subtypes.
if it's clinical presentation, but I feel like that's not going to be it, because I think we would have figured that out by now.
Yeah.
Psychiatry has been thinking about clinical presentations obsessively since
Yes.
Boiler and whatnot.
Yes, you're right, the phenotypes. Well, yes, biomarkers would be great. But, when you think of biomarkers, it's not just drawing blood and looking at genetics, let's say, and other fields of medicine have that. But it may be digital biomarkers. It may be neuroimaging biomarkers. There might be other, maybe with AI, who knows, we can analyze big groups of data and find certain markers or patterns. I don't know. But I think the hope, as you said, is personalizing or individualizing our treatments and hopefully having less collateral damage, if you will. If you can more precisely match the treatment, maybe you'll have less consequences of it, negative consequences. That would be my hope.
I think one of the things that also is worth thinking about, and I don't have an opinion on this yet, but I know that I think there's an article in The Economist about that, sort of arguing, should we actually consider adjusting, instead of forcing ADHD individuals to adjust to our situation, should we adjust more of the world for them? Which is, I'm sure, a very controversial idea, but it reminds me also of like the IEPs and the accommodations and things like that.
Well, that's a good one for adults. I think helping them understand what does their brain do well and what does it not do well. Yeah. And so if you're trying to fit a square peg in a round hole and try to be an accountant or something where you're sitting in an office all day, well, that's not the best profession for you. Or, other kinds of accommodations in home life and relationships and otherwise. I agree with you. That's absolutely. So with that, Ryan, I'm afraid we're going to have to wrap up. I really want to thank you for your time. It's been a pleasure meeting you and talking with you, and look forward to meeting you in person sometime. So thank you very much.
Pleasure to be here. Can't wait to talk more about this.
All right, and thank you for listening. And of course, for more of our podcasts, you can go anywhere you get podcasts and search under NEI Psychopharm or my name Cutler, because I'm listed as the host. And for more of our products, services, meetings, educational offerings, please go to our website, neiglobal.com. Thanks for listening.
Thank you for joining us for another episode of the NEI podcast. Please let us know what you'd like to hear more about by leaving a review. Don't miss another episode. Subscribe today. For more information about NEI and our premier educational content, please visit neiglobal.com.